And so good morning, good afternoon, good evening, everyone. I'm Trevor Hassel, President of the Health Coalition, and I have the pleasure of welcoming you to the first in a special webinar series that aims to build civil society capacity in the region to support the immediate and long-term health of Caribbean people, especially those living with NCDs during and beyond the COVID-19 pandemic. The objective of today's webinar, titled Civil Society Perspectives on COVID-19 and NCDs in the Caribbean, is to provide a platform for Caribbean CSO leadership to share and showcase their experiences, challenges, successes, and lessons learned in responding to COVID-19 as they plan for the recovery period, aftermath, and legacy beyond COVID-19. Today's panelists have been drawn from across the Caribbean and together with their teams have demonstrated unique courage and resilience as they have adapted their operations to respond to unprecedented challenges of the pandemic, which has disproportionately adversely affected the lives of people living with NCDs in the Caribbean. With limited resources, exacerbated by various stages of lockdown, the Caribbean NCD civil society community and its leaders have emerged as true champions as they adjusted their core operations to facilitate uninterrupted care, ensured continuity of access to essential medicines and critical treatments, or provided ongoing psychosocial support and healthy foods to maintain immune health. Today's roundtable will provide an opportunity for the widest possible sharing of the Caribbean NCD civil society response to the pandemic. It will take the form of two interactive panel discussions, during which panelists will make short initial statements, followed by discussion and a question and answer period. And so please type your questions in the chat box during the roundtable, which is being recorded and live streamed. And so the panelists for the first panel are Mrs. Deborah Chen, Executive Director, Heart Foundation of Jamaica, Mrs. Ruth Jamarillo, President of the Belize Cancer Society, Dr. Deanne Brathwaite, Medical Director, Barbados Diabetes Foundation, Mr. Andrew Danu, President, Diabetes Association of Trinidad and Tobago, and Dr. Bernadette Saunders, Provider Psychosocial Support, Bahamas Red Cross. With these introductory remarks, I now invite Mrs. Deborah Chen to share the experience of the Heart Foundation of Jamaica. Debbie.
Hi, good morning, everyone. Thanks, Professor Hassel, for the introduction and for the invitation. So by way of background, the Heart Foundation of Jamaica operates a medical facility. Initially, the biggest challenge that we had was to get people to continue to come out for their care. We remained open throughout the pandemic. I mean, it's still continuing. And we were classified as an essential service in Jamaica. So the various lockdowns of specific communities and the island-wide curfews did not impact us. However, it did impact the number of patients who came out for care. We initially had to focus solely on getting the message out that we were open. People were not sure, in addition to their own health concerns, they were not sure if they could come, if we would be there when they came to us. We had to use radio, social media, personal calls to patients. The response to the pandemic was of necessity fluid. We no sooner adjusted all our operations to one set of guidelines than it would change. And this change would happen overnight. We would close the facility, go home, and before we came back at 8 a.m., we had to completely change many of our operating procedures. So it was very stressful. We based all our decisions on WHO and the Ministry of Health and Wellness in Jamaica guidelines, and we had to keep focused because there was so much fake news from sources you wouldn't expect, as well as from the general public. So we really had to just focus on what was the real scientific evidence. Communication was critical to allay the fears, both of our patients and of our staff who were also fearful of contracting the virus. The Bloomberg project team, led by Barbara Margot, continued to promote healthy food options during this time in the face of increasing interference from industry, the people that produces the unhealthy foods, who were out there giving out their unhealthy foods under the guise of corporate social responsibility. We put in tight fiscal management. We had to have regular finance meetings, and we had to redo our budget. We did a few medical consultations online, but that most persons prefer to come and see the doctor. So the bottom line is based decisions on evidence, effective and timely communications, ability to adapt quickly to change, and prudent financial management. Thanks.
So Debbie, just a quick follow-up question. And so as you alluded to it, the WHO launched a report confirming really that there was a significant interruption of services to those with NCDs. To what extent, if at all, would you say this occurred as far as the services provided by the Heart Foundation of Jamaica?
2/3 of our services stopped completely. That was the emergency cardiac care island-wide training and the mobile screening services. Those were completely halted due to the various measures. The head office in Kingston, that continued. We were open fully and offered all services, but the uptake was very low initially. And it took us a while to get back. Right now, we're back where we used to be because people have now gotten used to the situation. So 2/3 of our business was down.
Okay, so thanks very much. I'm sure in the question and answer period there'll be some follow-up questions. I'd now like to invite Mrs. Ruth Jarillo, President of the Belize Cancer Society, to share her experience.
Good morning. The Belize Cancer Society experienced significant challenges during the COVID period. When the country went into a complete shutdown, that meant no access to our borders, which is Guatemala and Mexico, where most of our patients requiring radiotherapy needed to go. So that access was completely closed. In addition, we had to suspend some of the basic support services in the country, such as the diagnostic services like mammography, pap smear. There was very limited access to specialist services as well, as most of the hospitals and clinics had to redirect services exclusively during the period for only emergency cases. There was a significant impact on our resources, financial resources, especially for those persons who live in the districts who had significant challenges in mobility. I need to mention also that for a period, some of our districts' access between within the country itself due to public health measures was also limited. However, in spite of this, we had to mobilize quickly. We have patients who needed care, in particular the pediatric population. And in those cases, through our networks with our civil society partners, Ministry of Health and others, we were still able to use telemedicine to coordinate care for our pediatric cases in contact with Mexico. And so our patients were still able to get their much needed chemotherapy and other required services applying this approach. Since then, the offices had to reorganize. We had to do a complete shutdown of the Cancer Society offices in the districts, and the coordination had to be more centralized to maximize our resources. We had very close contact with our networks, including to support those patients who were in urgent care. And in some instances, our headquarters served as a holding area while patients were getting treatment, especially the pediatric cases. We are still facing significant challenges. As the country now begins to open its services more, there is an urgent need for coordination, engagement of our stakeholders, as the cancer response in Belize is still not considered a part of the national response. And so we still rely heavily on financial support from our donors, international donors, and our fundraising efforts. And because of the COVID epidemic, we had to suspend even those local fundraising activities like the cancer walk that would have given us significant resources to maintain support for the adult population. So these are the challenges we are facing this current time. And we're trying now to reorganize, coordinate, and mobilize as best as we can with the limited resources we have. Thank you.
So thanks very much. We'll come back again to discuss some of the issues you've raised later in the discussion period. I'd now like to invite Dr. Diane Brathwaite, who's Medical Director of the Barbados Diabetes Foundation, to share her experience. Diane?
Yes, hi, good day. Thank you for having me. So just a quick background. The Diabetes Foundation runs a multidisciplinary care center since 2014 with a gamut of services ranging from physician-led services, a foot clinic, diabetes specialist, nurse, nutrition, mental health, etc. I think our biggest development in this period was an expansion of our telemedical services. We had done telemedicine previously for short reviews, but what we had to do obviously was increase telemedicine for medical consultations. Telemedicine was solely for diabetes specialists, nurse consultations, nutrition services, and mental health services as well. We continued the diabetes foot clinic, tending to foot ulcerations, very high risk and pre-ulcerative lesions, but we were also seeing very high risk diabetic patients and urgent kind of consults as well, physician-based consults. Out of this, I think that we were actually able to improve our operations. We moved to a completely paperless means of operations through our health record, and those are things that we will keep. Other initiatives were an expansion of a medication initiative we had. I think that we were able to see what was happening in the world, and therefore we actually had planned for the various phases in advance of the arrival of the phases. So once the phases came, we were actually able to switch very easily into a new mode of operation, but it was a lot of work to actually plan for those modes. With the medication initiation, we would have purchased some medications in advance, non-formulary oral hypoglycemics and insulins in advance to keep as stocks for persons who may have had difficulty sourcing medication. We also supported the Diabetes Association with the Insulin for Life program and dispensed those medications from the center here. We also were able to generate self-management in education initiative called Diabetes and Heart Health. We partnered with the Heart and Stroke Foundation to do this, and we saw the need for it given the number of queries we were having pre-COVID. We also held a food drive, and through that initiative, we're actually into our 7th week of the food drive right now. Every week, somebody just pops along and helps us. But we've been able to deliver 200 food hampers to persons living with diabetes in Barbados, over 200 people, and we had a helpline. Something that I am proud of is that we also had a wellness check initiative whereby the nutritionists were able to make contact with patients who we considered high risk and vulnerable but may not have had immediate appointments. Just to very briefly mention our challenges, the psychosocial challenges were huge for patients and also among some care providers, financial challenges for patients, and also for us as well. Obviously, there was some loss of income during the shutdown period. There are challenges with capacity and also access to care. While we continued to be open, we did have visits from persons from the hospital and polyclinics and other care providers who had perceived difficulty with access to care, but they have all been repatriated to their care providers. Thank you very much.
So thank you very much, Dr. Brathwaite. It's quite evident that the Barbados Diabetes Foundation was significantly engaged in responding to the pandemic as far as its constituents were concerned. I'd now like to invite Mr. Andrew Danu, President of the Diabetes Association of Trinidad and Tobago, to share with us the organization, the experience of that organization. Andrew.
Hi, Sir Trevor, and good morning, everyone. So the Diabetes Association of Trinidad and Tobago was presented with many limitations and also opportunities due to the COVID-19 pandemic. At the very start, when we had our first case, we had to suspend all of our operations. So we had to suspend all of our meetings, fundraisers, screenings at our office and outreaches, because of course, many of our members are in that at-risk group where many of our members are living with diabetes and other NCDs, and many of them are elderly. So at first it presented many drawbacks and showed many, there were many limitations at first. But again, this presented a lot of opportunities for us because we were now forced to adapt. We were now forced, not just the association, but the membership themselves. We now had to have an increased social media presence, increased interaction with members and our followers on social media, as well as interactions through our groups, because a major part of the Diabetes Association of Trinidad and Tobago is our support groups, 18 support groups in Trinidad and Tobago, which meet, and that had to be halted. So we now were looking at ways to adapt technology using Zoom platforms, WhatsApp, and we have now started to develop a diabetes application, a mobile application, which presented a host of new opportunities for us to be able to monitor those persons we can't see physically anymore. We also were limited in terms of the funding that was available, and we had to innovate. So when we would have normally had a huge 5K, we now had to change that to a virtual 5K. And we had to look at other opportunities as well. For example, our children with type 1 diabetes camp, we had to change that into a virtual camp. So we are now doing a virtual camp in the month of August. And we would be opening it up to other diabetes organizations around the Caribbean. So it presented a lot of opportunities and limitations to us. We, however, are concerned that at the end of the pandemic, post-COVID, there may be a spike of NCDs, spike of diabetes cases, simply because patients are not taking care of themselves as they should during the pandemic. And we think that NCDs have been sidetracked a little bit. So that's our take at the Diabetes Association of Trinidad and Tobago.
So thanks very much. And your final comment and observation triggers me to ask you a question. So what do you think the government might do to assist your organization to make it more effective going forward in Trinidad and Tobago?
We are hoping that we get access to more funding, so that we could reach more persons. With our diabetes mobile application, we are trying to get it into the hands of more persons in Trinidad and Tobago so that they would be able to not only access our services, but be able to access physicians who they may not normally have reached out to. So many of our clinics have been closed in a sense. Many of our NCD clinics have been closed. And that is something that we hope that we would get this support for in time to come.
Okay, thank you very much. Let us now move on to Dr. Bernadette Saunders, who will share the experience of the Bahamas Red Cross. Dr. Saunders.
Good morning to all. The psychosocial support arm of the Bahamas Red Cross really actually started a while back, but it was mainly formalized as relates to Hurricane Dorian response. Luckily for us at the Bahamas Red Cross, we had the Zika Prevention Project, which the psychosocial support training was one of the activities And 2 weeks before Hurricane Dorian made its landmark on the Bahamas, that training was held. There were persons from the various government agencies and health agencies and the community as well who were trained. So when Hurricane Dorian happened, we were well poised to provide psychosocial support. The shelters that started due to Hurricane Dorian support, 2 of them are still in existence. And during the time that we were providing services as relates to Hurricane Dorian, there were many shelters and we were providing psychosocial support in those shelters as well. So that continued. What I'm trying to say is that some of the activities that we are implementing are actually strengthening of what already existed due to Hurricane Dorian. Hurricane Dorian exacerbated a lot of the activities that we would have implemented for COVID-19. So now we are just building on them and improving them. The various activities as relates to COVID-19 that's taking place at the Bahamas Red Cross, Meals on Wheels, where we supply a hot meal to persons in the community who may be affected by Hurricane Dorian. And when we talk about going to persons, we are also looking at their needs as well as relates to psychosocial support. So for us, we are ensuring that persons, the volunteers who are delivering the Meals on Wheels are psychosocial support trained so that they will be able to identify the psychosocial support need of the person and be able to provide that support. We also, when COVID-19 started, as a matter of fact, we had at least 2 weeks to prepare before the country shut down. And what the Bahamas Red Cross did is we prepared, first thing what we did was we prepared the staff. We had a session where we talk about COVID-19 and also what are their responsibilities and what the working hours would be like. So they were well prepared to act when the country shut down. We also developed a chat group by WhatsApp where we were in contact with the staff at all times, and that chat group was also used to provide psychosocial support tips to keep them mentally stable. We also, at the Bahamas Red Cross, also implemented what we call a COVID-19 EOC meeting, and that meeting was held every day, where persons were kept abreast of what was happening, and so we could strengthen the activities that we were implementing as we go along. There was also setups in the various communities where we actually set up wash stations at the shelters, and we wanted to really implement the hand washing. So we set up and supported them with the portable hand washing stations, and we also set up these hand washing stations at entrances and exit to the Bahamas Red Cross. Yes, we had to limit persons coming in because, like I said, we are in the rebuilding stage of Hurricane Dorian. So we still have recipients of Hurricane Dorian who are coming in for relief. But we had to look at the social distancing as relates to them coming into the Bahamas Red Cross. So we implemented a call-in center, and also the case managers would call persons and give them appointments to come in for their relief efforts or whatever they needed. And also the call center was there to not only deal with Hurricane Dorian relief persons, but also COVID-19 persons who were affected due to loss of livelihood, and they may need support as well. And that call center is very effective in identifying those persons. Our main challenges is, as relates to PSS, is staffing. And like I said, training. And what we did also, you know, the Bahamas is made up of 700 islands, including Keys. 25 of them are inhabited, and we are separated by waters. But we do have Red Cross branches on all of those islands. So we had what I did is I facilitated a Red Cross PSS training for those leaders and their volunteers, and 40 of them were trained. We did that not only for COVID, but also we wanted to strengthen our hurricane preparedness response as well. So we continue with our training by Zoom as relates to PSS and hurricane response. But like I said, our main challenge is volunteers, because we have a large area to cover, including the family aspect of recruiting volunteers, and with recruiting comes training. So our take-home message is that, yes, you are prepared. You might be prepared and preparing, but you could never be fully prepared. And preparing really put something in place that you can build on. Like I said, Hurricane Dorian allowed us to have a structure in place that we can build on. It also allowed us to look at lessons learned that we can fill in gaps, and that is our way forward. And like I said, we have our challenges, and we're trying to really cope with them.
So thank you very much. I think at this point, what I'd like to do now is to hand over the moderation to Dr. Karen Seeley. Karen is a HCC board member and founder of the Trinidad and Tobago NCD Alliance. And Karen will take us through a question and answer period to conclude this first panel. Dr. Seeley.
Thank you very much, Sir Trevor, Prof. Good morning, everybody. I want to add my own welcome to all of you and thank the panelists for their very stimulating sharing of the experiences that they have had in dealing with COVID. As the Prof said, I am director of HCC and also a director of the Trinidad and Tobago NCD Alliance. And many persons have asked me, well, what has been the experience of the Alliance itself? So let me just share with you for a minute or two and say that actually it's been very limited as an alliance. However, all our member organizations have been working with their particular constituents. And so for us, the lesson is, this is the first time that we've had an alliance with an emergency, and there will be other emergencies such as hurricane. So we see the need immediately to in fact have a strategy to deal with the issues that an alliance should deal with in terms of the advocacy at the national and other levels as we go forward. So that you've also heard from one of our members, and that is Andrew from the Diabetes Association of Trinidad and Tobago. So that's our experience, limited involvement with the formal response, but we hope to have more as we go forward. I'm going to be asking you to put your questions through the chat so I can pick them up very quickly. And I have a question here from Alison Bernard, directed to Dr. Brathwaite. What are the operational or other aspects of the changes you had to implement during the pandemic will you continue to integrate as a major part of your services? You mentioned going paperless. What about the telemedicine on a larger scale? So perhaps my panelists, it might be useful for the panelists to all show their videos. Yes, please, so that quickly people can see who you are. But this one is for Dr. Brathwaite.
Yeah, so telemedicine, I like to think of it as telehealth. Yes, we would love to expand telemedicine, but also remembering our population. For some people, it is clearly not appropriate, and it is not ethical to use it when it's not appropriate for a person. So understanding who you're going to use it for, and when you need to have that person in front of you. But certainly we would love to be able to expand telehealth, even maybe to other islands, and also thinking about using telehealth for the purpose of CMEs. I think this will be a big drive forward, as we can see, patient education, care provider education, and networking, meetings, planning, and also support groups. So that's something obviously that I'd like to encourage the Trinidadian Association to further do. Think about how you can work on developing your support groups using telehealth. There are quite a few things. We've been approached about a Meals on Wheels program, and so I think gradually we will transition our food drive into supporting Meals on Wheels program, possibly with the Red Cross. And I think the most important thing is just developing partnerships, working very closely with other associations. and supporting efforts and seeing how we can partner to pool our resources to get the things done that we need to do.
Okay, wonderful. Thank you very much. Andrew, you mentioned, in fact, a very innovative approach you're taking with the diabetes app. Tell us a little bit more about it, so that exactly what are the elements of the app that allows you, in fact, to have accommodation with all of your clients, including those who are visually impaired.
Yeah. So the diabetes application is almost ready for launch. One of the features, in particular for the visually impaired, we're going to be able to have audio commands and audio responses on the application, and the ability to enlarge the screen if that is necessary. So those are two features of the application which would be suited for those visually impaired persons. Beyond that, however, the application is also going to be multilingual, Spanish especially. So there is going to be a Spanish feature on the application, simply because we know of the large amounts of Venezuelan migrants that we have in Trinidad and Tobago. And we know as the association, if we don't work with these persons, then they are not going to get the help that they probably would need. So we have now taken the initiative to start to expand our services to Spanish speakers and have these facilities through the application. But the application as well, it would be able to, you'd be able to enter your blood sugars. You'll get prompts on when you should test, when you should do HbA1cs. If it is elevated, messages are going to go directly to your health providers, and the prompts are going to be automatic to tell you what you should do. So
we actually could see this as a pilot for a Caribbean diabetes app. So hopefully we look forward to that very much. So I'm just looking to see if we have other questions. I do have one, and that is, almost all of you mentioned the use of the various platforms, including social media, to increase your communications and for different things, including, well, of course, telehealth is one. Give us an idea of at least sort of one serious challenge you had with that, in terms of the use of, let's say, for communication with clients, with patients. What were the challenges that you had in terms of? Anybody want to take that question?
I can start it. Yeah, obviously would be the person's comfort level with using social media. So for example, even with our self-management initiative, for example, with Instagram, you're dealing with a younger population of patient, whereas you have to have it on Facebook as well to cater to the older person. People tend to be interested in slightly different things depending on their age or their experience. In terms of telehealth, we moved very quickly to video conferencing wherever we could, because we found that to be much better, obviously, than just simply having a telephone conversation. The video conferencing obviously allowed for things like engaging family members more, and it was a good thing because we had family members sometimes who never get an appointment, and we were able to engage them in the consultation. It allowed us to check things like insulin draw up, if they were drawing up properly, if a person had a problem, were they using their meter properly, injection technique. So that was the benefit of video conferencing. But of course, the problem is that everybody didn't have access to video conferencing.
Okay, thank you very much. I have a question for Bernadette. I've forgotten who it is asking specifically about, you get a lot of psychosocial support for patients, it seems, and even the general public. What about your staff? How did you support the staff who were doing involved in that, to ensure that in fact their needs were being met? Bernadette, you can unmute your mic, please, Bernadette.
Sorry. First of all, we had a meeting with the staff that put them in that put them at a level where they would be able to cope. And we developed, like I said, we developed a chat group where we communicated with them on a daily basis, and we did activities. We send out PSS hints. We encourage persons, if they need to talk privately, and also during the long shutdowns, we did lots of activities with them, trivias, games, and all those different things. So that's how we were able to cope with keeping the staff mentally stable during that time.
Thank you very much. I'm sure you would all have had these challenges for your own staff, whether they were actually delivering psychosocial support or not. I think we've come to the end, just about the end of this session here. I'm just going to ask one question that stimulated. We talked about the visually impaired. What about the physically disabled, physically challenged clients that you had? Was there any organization that had a particular challenge with that in terms of for them receiving services? Just a quick question to anybody. This is a short one to wrap up.
Well, I would say Barbados is very small, so a lot of our elderly persons who absolutely needed care were able to get somebody to bring them here, though there was a huge fear for them in terms of coming out the house. But I think we're fortunate in that in difficult circumstances, we would actually go to some persons as well. We'd go out and go to their homes if they couldn't get to us.
It's so important for us to think of all the disabled persons as we go forward. We have had answered just a few of the questions. I just want to let everybody know that we are going to be analyzing the questions and making sure that those of you who have asked questions will get responses after the webinar, either from HCC or directly from the person to whom you asked the question. So I will wrapping this up now so that we can go to the next panel. And it is now my pleasure to introduce Dr. Damian Greaves, who is a colleague on the HCC board with me, someone I've known for quite a while in the areas of health. And he is the chairman of the Grenada National Chronic Disease Commission. And Dr. Greaves, Damian, you're going to take over the second panel, introducing the second panel. And at the end of that, I'm sure we'll have time for even further questions. Damian, over to you.
Good morning, everybody. Thank you for that introduction, Dr. Karen Seeley. Good morning to everybody. I am sure everybody is now thinking of how we're going to emerge from this rather COVIDious experience. I have a distinguished panel of 5 individuals. I just want to say, first of all, welcome to all of you. I want to add my words of welcome. And as you heard, I'm the chair of the Grenada Chronic Disease Commission. We are, in fact, that COVID-19 gave us an opportunity to be even more visible, or to definitely be more visible in terms of the Grenadian populace. What we have done after COVID-19, with this COVID-19 experience rather, is to look at NCDs in the face of COVID-19. And so we have prepared what I call talking points. We have developed a program along with one TV station called Healthwise, where we are voicing messages. We are also trying to add to that the animation of our messages and so on. And our topics are looking at backyard gardening, food and nutrition, vitamin D, mental health and depression, the use of salt and sugar. We want to ensure that people understand that. So we are also looking at voices of the people. We have now prepared what we call an agreement. I don't want to call it a contract, an agreement where individuals who have decided to be part of the voices of people living with chronic diseases will actually sign up, and then we are preparing to get that organized. I want to say to you that we are very concerned about mental health. So we are talking about mental health literacy. And we are thinking that backyard gardening is too cliched, and we want to call it essential gardening, with a logo and theme that will speak to growing delicious food for essential living. With those few words of introduction, let's get right into the panel. And I'm sure my panelists are ready. Let me just introduce them very quickly. Dr. Kenneth Connell, President, Heart and Stroke Foundation of Barbados. Dr. Tamara Remy, President of the St. Lucia Cancer Society. Dr. Nancy Larco, Executive Director of FADIMAC, Haiti. Mistress Juanita James, President, Antigua Diabetes and Hypertension Association. Dr. Mark West, President, Thoracic Society of Trinidad and Tobago. We will begin with our first distinguished panelist, Dr. Kenneth Connell, and ask a very pertinent question. Can you, sir, briefly describe how your organization has responded to COVID-19? That is your Heart and Stroke Foundation organization of Barbados. Welcome, my good friend.
Good morning, Dr. Greaves, and thank you for your very warm Grenadian welcome. Thank you to the HCC for hosting this very relevant webinar. So I'm president of the Heart and Stroke Foundation of Barbados, and briefly the foundation was established in '82. We added stroke onto Heart Foundation of Barbados in 2006, and we are an established charity in Barbados. So my two interventions are going to be briefly speaking to our agility and to respond to this pandemic. And I will use 2 R's, our responsiveness to the public need, and secondly, also remote services. In response to remote services, we offer the American Association of Cardiovascular and Pulmonary Rehabilitation accredited cardiac rehabilitation program. We're very proud of this. It's the only one on the island. As a result of physical distancing and lockdown measures instituted by the Barbados government, this program was paused temporarily and had to be offered remotely. This was an accredited kind of transition because the template was provided by the American Association of Cardiovascular and Pulmonary Rehabilitation. And so our clients were able to continue their exercise routine and so to avert possible complications such as heart failure and all of those other things as a result of them losing rehabilitation. And secondly, then there was responsiveness to the cardiovascular need, well, a pandemic need, I should say. And so we noticed that there was quite aggressive marketing by fast food retailers in Barbados offering alternatives, especially disguised as frontline worker alternatives. And so we launched the healthy food packages in conjunction with the mitigation unit of the Prime Minister's office here. And so I'm very proud of our Barbados Childhood Obesity Prevention Program. And the doctor who led on this, Dr. Kia Belgrave, established, and we have given out more than 400 hampers. So briefly, we responded to agility, responsiveness to a pandemic need, and also in terms of providing remote services with CDPNR. Thank you.
Thank you. Thank you very much. Thank you very, very much. That was really a lot to bite and chew on, Dr. Kenneth Connell. I call it SNS, short and sweet. And I want to talk about your 2 R's, the responsiveness to the public need, the remote responsiveness, the agility. And all of that is really, really important. Let's move to the second panelist, Dr. Tamara Ramey of St. Lucia Cancer Society. Your turn.
Good morning. Thank you for having me. As you introduced, from St. Lucia, our society is very different to that of the Belize Cancer Society, where we have a very small volunteer-based group, and we have moved away from service provision and focused mostly on education, advocacy, and support. A lot of our support has been financial to our members. Pre-COVID, we had established a WhatsApp group for our members. We had done quite a bit with Facebook, Instagram, and education dissemination through newsletters. Our knee-jerk response, because we had to close our offices, was really, once everything was safe, to be able to get out there and deliver what we thought was the most basic of needs to 2 populations, 2 groups that we thought were the most vulnerable. One was our cancer patients, and we had a little bit of difficulty trying to identify exactly who these people were, because as I mentioned, most of our members are volunteers. But we were able to engage other cancer care organizations. We were able to tap into the oncology clinic at our public hospital, and we were able to identify maybe 10 of our patients that we felt really good about donating full packages, veggies, healthy foods, to them, and we delivered them to their houses. Our second identified group was our children's group. So we had embarked on a school program prior that dealt with healthy living, and we were able to reach out with this group, and we chose our first school, which was in our own community. And this is something that is currently ongoing. So we have a food drive, and we're hoping that next week, Tuesday, we'll be able to deliver to maybe 30 of our students who have really been displaced as it pertains to their school feeding program. We are embarking also on our backyard gardening, as well as trying to engage stakeholders as we anticipate mental health issues following COVID. We've had to step out of a lot of what we are accustomed to doing and think outside of the box and look at ways that we can engage other CSOs to deal with the immediate problems and then the later ones, which we expect with this third wave following COVID.
Right. Thank you very much, Dr. Tamara. Thank you very, very much. That was a lot again, Dr. Tamara Remy. I'm interested in the idea of moving from the point of offering services to education, advocacy, and support. And I suppose that a little later we can speak about that after we have heard from our panelists and so on. And I like the idea of thinking outside the box instead of filling the box. Thank you very much, Dr. Tamara Remy, whom I know very, very well as a St. Lucian. Let's move over to now Dr. Nancy Lako, the Executive Director of FADIMAC Haiti. Bonjour, Sakafet.
Kembe, thank you very much for giving me the opportunity to share with you what is happening in Haiti. So I should just telling you that COVID-19 found Haiti struggling with lockdowns, political lockdowns, and a lot of difficulties, mostly economicals. So our first 2 patients with COVID was diagnosed in March 19. But even before, with all what was going around the world, so we started beginning of March informing the patients and giving press papers, and so the radio could give the information to the population. So we should say that FADIMAC is a non-profit organization and charity organization also, and we really focus on diabetes and cardiovascular disease. So we give educational classes, we have affiliated centers across Haiti. We do also have medical clinics for diabetes, cardiovascular disease, renal disease, and also gestational diabetes. And also we have a food clinic. So there are a lot of activities, so we had to make a decision. So we stayed open regardless all the challenges that we faced. So it was difficult for us. So we had to see with our employees, our 25 full-time employees, to see how we could make a rotation and be able to give services. So we also, because of the patients hearing that they would be at risk, so they were afraid to go out. So a lot of, at the beginning, we had a really decrease patient coming to our facility. So what we did, our social workers started to call them, telling them that we were open. And now we are working on a program for the type 1s, mostly thanks to Life for a Child, where we have our social workers and young leaders, of course, using the preventive measures and also everything to protect them so they can go and be closer to those patients and being like a bridge between the patients and our medical staff who are still at our facility. So we should say that even with the decrease of incomes, we were able to continue, thanks to God. And then so we also made a position statement for the medical personnel across Haiti, and the Ministry of Health is using that paper to make people have the same protocol for patients with diabetes and cardiovascular disease, mostly hypertension. So also we also have for our clinic, so as the means of the patient really decrease and their economical status really low, so we were able to have medicine from Food for the Poor and WHO, so we can distribute it freely to the patients. And also we are working actually on a hotline to inform the patient, because in our society, people think that they are at risk to develop COVID-19. So we had to tell them, no, you are not at risk, but if you have diabetes and cardiovascular disease, you may develop complications, more severe complications. So you have to prepare yourself. So this is what the kind of messages that we are giving, using on our social media also. And now we are working and looking for funds for develop a networking to be a support for the physician across Haiti to be able to, of course, take care of patients with COVID-19, but mostly patients with diabetes and cardiovascular disease, so they can be more comfortable to take care of those patients. So it's a lot of things going on. Unfortunately, the Ministry of Health is so overwhelmed, so they don't have the time to and financial possibilities to help us. So we are relying on local people who are still seeing the work that we are doing, and also on the international, where we are working on to facilitate our patients living with NCDs, mostly diabetes and cardiovascular disease in Haiti.
Thank you very much, Dr. Nancy Lacko. That again was a brainful. We're talking about fighting vulnerabilities and fears, using social media, press releases, communication and information generally to fight those devils of the vulnerabilities and the fears that Haitians would have in your country. Thank you very much for that input. We now move over to Mistress Juanita James, President of the Antigua Diabetes and Hypertension Association, to tell us, to briefly describe how the organization has responded to COVID-19.
Thank you very much, and thank you, HCC. The Antigua and Barbuda Diabetes Association, although we do incorporate hypertension, we are primarily a support group, and we are engaged in education and screening in various settings. The first confirmed case of COVID-19 on March 13 halted activities we were engaged in for World Kidney Day. And usually we have monthly meetings which have now been suspended. But prior to even having the first case on island, we try to strengthen our information and communication through our WhatsApp group, telephone calls, and also using Facebook. Because of the closure of clinics, pharmacies, etc., we paid a lot of attention to self-monitoring and self-management. So through those communication means, we kept in touch with our members to promote and support improved self-management. Another area that we were involved in was food and nutrition, in terms of distributing fruits and vegetables to our children living with diabetes, a small group of children we have. As well, we had an existing program of a breakfast program in one of our primary schools. And after schools closed, we were able to link the children who were vulnerable children to the National School Meals Program so that they could continue to receive lunches, and after a while, when lunches had stopped altogether, to receive food packages for those families. As well, we are promoting backyard garden to help to promote and support healthy eating within family settings. So we have been able to stay in touch with our members, but we are concerned that some persons are afraid of going out to health centers, even though they have reopened and services are being offered, because of the fear of contracting COVID virus. It still remains. Thank you. My time is up.
Thank you very much. Thank you very much for that input, where we emphasize the disruption of ongoing activities and having to stay in touch by networking and communication, keeping in touch with the membership and so on. Thank you very much for that. We now move on to our final panelist. That is Dr. Mark West, who is the president of the Thoracic Society of Trinidad and Tobago. It's your turn now, Dr. Mark West.
Good morning, everybody. Let me first off start by thanking the Healthy Coalition, the HCC and its directors for inviting me, and Ms. Mayasha Hutton for bringing me along, and to also be part of this very stimulating initial meeting. So I am the president at the moment of the Thoracic Society of Trinidad and Tobago, and this is an umbrella organization for all respiratory disorders and surgical aspects of them. I am a surgeon by training. Specifically with respect to COVID and its impact, I have a particular interest in lung cancer, and what we have noticed is a reduction in the number of cases being referred for assessment for lung cancer and therefore diagnosis. This will translate, unfortunately, into a reduced amount of treatment and lives saved for lung cancer in the year when we do our analytical figures. We're down at this present time about 43%. Speaking to my other colleagues, this also fits in very much with the picture. They have been seeing a reduction of cases with patients with COPD and also with asthma presenting for treatment. This, we believe, is related to the fact that the government itself had issued quarantine measures and stay-at-home measures, as well as patients' fear of coming into hospitals and either being exposed directly or indirectly to disease. What we feel this is going to see, and we are beginning to see it, is that we're having a rebound increase in the number of cases being referred at this time for asthma and COPD. On an organizational front, we are, as TSOT, participates in numerous meetings. We've had the cancellation of World Asthma Day, which was May the 4th, which we would have participated in. And we also had the cancellation of what we participate as World No Tobacco Day, which is May the 31st. We tried a workaround where we presented work on what we did on the HCC, so that we would normally participate with a school poster competition for World No Tobacco Day. And as we could not interact with the children, although we had started, we had to postpone it. We utilized past works that they had done and we presented it there. So we were able to show what they had done. Again, it was really just to highlight World No Tobacco Day and the problems with it. So just to summarize, COVID has had a very direct impact on respiratory disease, and we have had a few indicators of the significance of this, both in the population and professionally in meetings. And what we expect, what we're seeing now is a rebound increase in the number of cases coming forward as we begin to reduce the restrictions. Thank you.
Thank you very much. Very important, Dr. Mark West. You talk about the rebounding increase. Could you share your thoughts on how we can go about managing NCDs in terms of the pandemic moving forward? How do we manage those kinds of diseases within the confines or the environment of a COVID-19 experience?
Thank you for the question. I think we're beginning to do that now. We are coming together and sharing ideas. We've got a large number of ideas. I'm looking forward to, and I would promote the summary, a summary report so that everybody can see it clearly what we're doing. So when you speak about NCDs, I think we have to break it down and look at each major category of NCDs specifically, and we know what they are. And then we need to look at the individual solutions. Some can be shared, some are common across the board. We've heard about the psychosocial issues. We've also heard about economic problems. We've also heard about, or we're not directly about, we have heard what the Barbados Association did in terms of gathering insulin. So the medication and the pharmaceutical aspect of it, where people will struggle to access these things. So I think what we could do is we could, as a start, look at what we across the Caribbean have been doing and produce a summary report, and then as you could say, the challenges, and then we have solutions that have been implemented. We've seen the app program from the Diabetes in Trinidad and Tobago. So I thought we provided quite a few stimulating solutions to these problems. And I think, of course, we need to break it down by all the various NCD subgroups.
Thank you very much. Thank you very much, Dr. Mark West. I really appreciate that response, and I think we can look forward to that, that summary report of the challenges and solutions and so on. It's now left for me to hand over to the Executive Director of the HCC to look at the question and answer session, the inimitable Maisha Hutton. It is your turn now, Maisha. Thank you very much for the opportunity.
Good morning. Thank you, Dr. Greaves, and thank you to the panel that just went on. Excellent panel. Can you all turn your cameras on, please? and we can go into some questions. So we have some questions in the question and answer section. I'm going to start with Maria McIntosh. She's asked, what provisions are being put in place by various bodies to accommodate the persons with NCDs who are differently able, those with mental health issues or elderly, especially those who are not tech savvy or don't have internet access? Does anyone want to take that question?
This question was asked really to be able to be more close to the people with NCDs. So what we did, we used a lot of calls. So the patient is hearing, even they use WhatsApp, they use telephone, but it's technology. So we talk to them, our social workers talk to them and then give them information. So we have also a questionnaire that we are filling for the young type 1s. So we can see, and our psychologists can see what is their social, psychological profile. So, and then get back to them and see what she can help them.
Okay, does anyone else want to jump in on that question? Okay, Nancy, I'm going to follow up, and it piqued my interest as well, but we have a question from Pierre Cook. He asked that you mentioned that there was training of young leaders who supported the outreach to parent patients into the community. Can you tell us more about that? Were they trained? Is this outreach specific for the pandemic period? Just tell us a little bit more about that youth engagement piece.
Okay, since the earthquake, so since 2010, we had a program, a community outreach, where we use the young leaders to go to the community and teach, especially in health centers, because at that time, and then from the health center or the area, have groups to meet. So we had a very good experience at that. And some of them, they left the country, but a lot of them, they are continuing. They have each month, one day of the last Friday, a support group. And the oldest one or the more experienced one, they are leading. So we also train them again. So it's a continuous training for them. And then so they can be not only a resource, because each of them are responsible of a certain number of youngest one, so they can watch after them. So they have to know what answer to give on hypoglycemia, on some symptoms of hyperglycemia or coma. So even when the patient is at the hospital, they are the relation between FATIMAC and the family, so they can be, everybody can be informed of. So training is very important. So it's not only medical so information on diabetes and hypertension, but also on the community outreach. They have a training on that, and we have a volunteer who works with them on that.
Okay, thank you. Renee West has a question. She says, there's been quite a bit of miscommunication and myths around COVID. How have each of you tackled this in your own organizations with your clients in your community that you reach out to on a daily basis?
So Maisha, if I may respond to that, is that fine? So the one positive effect of this pandemic, hopefully this is the legacy, is that it teaches us how to build contingency plans. And my message to all of my colleagues in civil society organizations would be, in your strategic plan, you have to construct contingency plans, because we may be living in a landscape that isn't familiar. And so the question about COVID and responding to the fake news and misinformation has come up with almost every interaction we've had, whether it's been in remote CDPNR training, whether it's been in giving out the healthy hampers. People want questions answered, and they look to the healthcare fraternity to respond. What I think that is helpful is to have some of these commonly asked questions scripted, so that everyone from your organization is speaking on the same page and giving very accurate information. What you do not want is for different mixed messaging to come from within the organization. And it might be helpful, for instance, if an organization like HCC, which might provide the platform to have these cute FAQs, so that all organizations say, well, here are the FAQs that we've gathered from around the region. Here are some suggested responses using the specialists in those areas. And I'll end there.
Thank you, Kenneth.
Sure.
I've got a question I think I'm going to pose to Dr. Remy. It's from Catherine Pettis, and it's about palliative care. Can you please talk about palliative care for persons with NCDs? The WHO has an updated set of guidelines on inclusion of palliative care and during COVID. And so can you speak about how that is relevant within your organization?
Well, unfortunately, while in the past, the Cancer Society had actually been the lead when it came to palliative care, we've actually, I think that aspect of especially cancer management has actually kind of been left behind. And as I mentioned when I presented, we have transitioned from a service provider sort of stance to more of an educational one. And I must at this point say that in St. Lucia, we had a very peculiar situation. So the economic crisis, et cetera, that has affected every one of us, that's not unique. But in St. Lucia, we actually, in the midst of all of this COVID, had to change facilities for our public health institutions. So we moved from our normal Victoria Hospital and an unplanned movement to a new hospital, which is where most of our oncology services are delivered. And so apart from just the immediate interruption in the delivery of healthcare, we have a continued disruption because things that would have normally taken a little bit of time to put in place when you move facility, we've actually not been able to deal with that. So what we're actually seeing is, and I'm sure it extends to palliation, is that we've had a severe disruption in delivery of even the therapeutics to those persons where we talk about curative. And so a lot of our palliation has most likely been affected. And as Mark said, there's been a delay to even screening, to diagnostics. We've seen a reduction in the number of patients who've come to the hospital or even to our private doctors just to get their diagnostics done. And that automatically translates to even treatment. So while I don't have the figures or can talk about palliation as a whole in St. Lucia, I have no doubt that our palliation and any movement in that aspect of cancer care has been significantly affected by COVID.
Okay, thank you, Tamara. I mean, and this also speaks to the ability for you to comment on this, speaks to the relationship between the civil society organizations and healthcare providers such as yourself, and the possible advocacy role that civil society organizations can play in promoting the continuity of care of people living with NCDs throughout disaster situations like this. Does anyone else have any comment on that? On that question on palliative care? Okay, let's move on to another question. We've got one here from Jared Spencer, and it's about food security. It says, given the current spotlight on food security in the region during the current pandemic, what role do you see the local agricultural sector playing in the prevention and management of NCDs in the Caribbean? And before I open this up for anyone to answer, you know, this is a critical area for us because we know that many NCDs are related to diet, right? Diet's one of the major factors leading to NCDs. And as a result, the HCC and the OECS Commission launched a joint statement earlier this year, really asking the region to prioritize food and nutrition security within the context of COVID and beyond. So, you know, when we hear Dr. Greaves and Juanita talking about backyard gardens at the level of the household food security, there is a real need for us to address regional food security. And this also comes into play when we hear Dr. Connell talking about the healthy hampers and the need to ensure that even in situations as this, we are promoting healthy diets amongst people living with NCDs and the larger community. So does anyone want to comment specifically on this idea of food security and engaging local agricultural sectors?
I think there's a great opportunity here because in most of our islands, I'm sure that we do have a food and nutrition security policy, and in our NCD policies as well, that food and nutrition security is addressed. So I think we have a great opportunity here to strengthen these links and to work together with ministries of agriculture, not just with the, as you say, with the backyard garden projects, but in a general, more national effort and regional effort.
And Maisha, if I may expand that landscape on food security and to suggest that civil society organizations now have an evolving role to speak to the social determinants of health including food and food security and climate change and all these other things, trauma and domestic violence, all those things that impact on health, we now have a responsibility. And specifically to food security, we now must highlight this as an impact on health directly to our governments and our ministries responsible. We now must suggest to them how they might mitigate and forecast these deficiencies. So I think this is an exciting and evolving role of civil society organizations to speak to the social determinants of health, but especially food security and climate change.
Maisha, can I interject very quickly? I thank Dr. Connell for his comments. I think he's touching on a very big goal, which is leadership. And I won't get into my platform on that, but I think we all have an increasing role to play in leadership. And one of the reasons that our societies are weakened in some areas is factors that has not been addressed directly or continuously in the past. We've all had great political leaders, we know about them. But behind all that, and this pandemic gives us the opportunity to come to the fore in some areas, as well as the organizations, but as well as the individual problems.
Absolutely.
Thank you, Mark. So we have a few more questions, quite a few actually. I'm actually trying to navigate through these. One question is from, let's see, it's from Aloma Bain Street. And it says, has anyone noticed increased use in alcohol, drug use and abuse, increase in family abuse, conflict issues, and just generally coping? And then tied to that is you know, the broader question of mental health and how we're coping through COVID.
Can I make a quick comment on that?
Yes, go ahead.
I would have to testify without evidence because, and I'm very concerned about that statement, but I'd like to do some research into this. However, in my experience, I was shocked to see examples of elderly abuse related to problems in my area with people who had fluid in the lungs. And I saw an example of this, and it opened my eyes to it's probably a very big problem, elderly abuse, and COVID with the economic challenges as well as the drug abuse challenges this person was alluding to is probably very, very significant.
And Maisha, I think one of the most significant things that could come out of that is measurement and measuring those metrics. You know, how I know the University of West Indies, for instance, is involved in looking at the impact that COVID-19 has had on mental health, but we should really be delving deeper into physical, mental abuse, people who are suddenly finding themselves in a household almost trapped with people they weren't familiar dealing with before, and really they have no release. So I think that this is another area that there are lots of novel areas civil society organizations may get involved in, posing those questions to academia and suggesting that academia now research those questions because they're translational research, and it's very relevant to the pandemic.
Yes, thanks, Kenneth. Agree 100%. What I'm going to do now is just switch things up a bit in the sense that because the first panel got cut off, well, you know, I'd like to include them in this discussion. So I'm going to ask the panelists from panel 1 to turn their cameras on, and let's see if we can engage them in this discussion as well. Certainly we can get Ruth to answer some questions around the palliation. I have a question from Karen Seeley. Dr. Seeley, while panel 1 gets their cameras cued on, what are the lessons for civil society? What lessons have we learned to prepare for a combination of COVID and other emergencies like hurricanes? Does anyone want to take that one? Andrew, do you want to go ahead and take that question? How can we learn from these experiences to prepare for future emergencies?
So Maisha, I think the one thing we need to do to respond to this is it has to be part of an action plan. When we plan our strategic planning for 2 or 4 years or whichever long we do so, we have to plan agility into it to respond to emergencies. Or not, we are inept. We suddenly scramble to have these kind of, we respond in an emergency situation, but it's not in a holistic or strategic way. So the one thing the Heart and Stroke Foundation of Barbados has learned is that we will never find ourselves in this situation. Agility and strategic planning for emergencies has got to be in our plan. And it can't be just a temporary emergency like a hurricane. It has to be an emergency that changes our entire landscape and how we interact with our clients.
Yeah. And you know, go ahead, who's that?
Tamara, I was simply saying that I think our approach also needs to be a combined one. So I think as an NCD alliance, I think locally there should be more of a movement to get all of our civil society organizations together so that we have a joint plan and we tweak accordingly to the specific disaster that has occurred and our specific needs thereafter. But I think jointly, food security, accessibility to medications can be applied across all of our organizations. They're not unique to health and to heart and stroke or to the Cancer Society. When it comes to specifics, for example, chemotherapy or access to those things, you know, that are specific to the individual organizations, then yeah, we need to have that individual plan. But I think apart from just that regional NCD alliance, there needs to be something on the ground locally in each island that allows us to automatically act whenever we have a crisis like this. Because I can see that this is just the first, and you know, I don't know how many of us have been very successful in, you know, maneuvering our way through it.
I'd like to comment, if I may, in regards to the Belize experience. Besides dealing with the cancer situation as the president, I'm also the health services manager for the National Health Insurance in Belize. And the challenges in coordinating both services has been very critical for us. There has to be a joint plan, not only within civil society, but also with the national partners. To ensure the continuity of services. What we found was a huge fragmentation of services during this state of emergencies. What needs to be done is a clear guide. First of all, a standardized approach to this type of outbreaks or epidemics. What are the facility requirements that need to be put in place to ensure that it offers the maximum protection for the staff, the health professionals, as well as patients when we have limited resources. Unfortunately, Belize doesn't have the luxury of having multiple access to PPEs, to the required medications, or even the capacity, hospital bed capacity for those severe cases. So in our case, we have to be very conservative in the approach to primary healthcare services. And the key aspect of this was coordination. We need guidance. Someone mentioned leadership. Leadership is key. We have to have a national response for this type of prolonged state of emergencies. Clarification on what are the proper standards, what are the appropriate referral pathways. This was a significant challenge for the Belize Cancer Society. And while right now we're not engaged in actually giving provision of services, I wanted to clarify that even though Belize is looking to establish, the Cancer Society is establishing an additional suite for chemotherapy, the idea is that we are directly responsible for coordinating the case management and navigation of patients that are coming from all parts of Belize. And for us, the huge challenge remains where when our borders were completely cut off, what are the measures we can take then for patients with cancer? And that's a major concern. We don't have access to radiotherapy at the current time. So we've had some deaths because of that. And we still have a pediatric population that the teleconsultation was very effective. And we need to explore this engagement with health professionals within the region to support local countries like ours to be able to continue managing these cases. Thank you.
Go ahead, Damian.
Yes, I just wanted to say, for example, I think it's so important, those discussions that we are having. I do not see how we can separate health emergencies from natural emergencies or health disaster from natural disaster. Grenada, to me, is a perfect example of where there was a marriage between NADMA, the National Disaster Management Agency, and the Task Force for Health and the Ministry of Health. I got the impression that that NADMA was in charge of the quarantining stations. They were in charge of making sure that certain things were kept in a particular way. That is the impression I got. But I'm saying, even as we look now, with the pandemic raging on in certain countries and the possible reemergence in our countries, the hurricane season is upon us. The two, therefore, there must be some synergy between disaster preparedness and the health emergencies that we are now experiencing. So I think this has to be part of the strategic plan going forward.
Thank you, Damian. And this is all part of this idea that we're hearing more about building back better, right? And learning from the lessons of this experience. And also, I think what you've touched on, Damian, is the importance of learning from countries in our region who are reeling from hurricanes and have had the experience of dealing with ongoing disaster. And how do we learn from those experiences as well? So I want to make sure we get to a few more questions that we have here. This one is an observation. It says, on the topic of mental health, we at the Cancer Support Services have been seeing a significant increase in the need and requests for counseling, especially amongst persons who lost their loved ones to cancer during this time. So how are you all coping with this increased mental health, the increased mental health needs of your clients and your partners? Has anyone had any of you have dedicated mental health counselors that work with patients?
For Belize Cancer Society partner with the Belize Family Life Association, and we had volunteer counselors available to be contacted by phone for families that are coping with palliative care or terminal patients at home. So they were able to access that support by calling in. And also one area that we also had to take into consideration is because we were so limited in the ability to respond, even at the Belize Cancer Society, our partners, our staff, they themselves had to deal with certain level of stress and depression from losing some of their clients because of the sense of helplessness. They couldn't get to them fast enough, or the limited ability to respond where the cases were so significant. In some instances, we also need to support our health providers who are dealing with this type of loss to be able to cope and be able to stand up the next day and be able to provide a continuity of services. So yes, we have hotlines, and we need to strengthen that countrywide though.
Okay, thank you, Ruth. So we've got about a few minutes left in this session, and I wanted to give each of our speakers, 15 seconds to just give us some closing thoughts on this experience and how we can build back better. What's the priority? What's your number one or number two top priorities as you move forward to help you build back better, to move forward, to navigate this pandemic, and to do your job better post the pandemic? So let's start with, I'm going to start with Debbie. I'll go through the roll call. So let's start with Debbie from the Heart Foundation of Jamaica. Two quick closing thoughts on priorities moving forward.
I think that given the financial crunch that this has brought us to, we have to focus more than ever on our income and our expenses. Even though we always think that we're not spending more than we need to, when you really look at it, maybe there's ways we can be more creative, because you realize that we have been doing without certain things since March and we're still here. So you know, the creativity, how do we keep our expenses down? How do we make use of opportunities to get our message out without incurring the cost? You know, when you look at the positions within your organization, are they all really necessary? Can some job descriptions be redefined? You know, so I think it makes us into a leaner, more nimble organization, because even though we think we're doing our best, when you actually look at it, there are still ways we could have improved promoting our services, which we managed to do, and also ways that we could have reduced expenses.
Okay, thanks, Debbie. And let's go on to Ruth. So your quick priorities moving forward.
Learning from the experience, establishing clear guidelines for future outbreaks such as this, and also the management of NCDs with key close partnership with our Ministry of Health and other relevant stakeholders, and sustainability measures, financial sustainability measures, as each of our countries are facing economic challenges. what would be the best approach to rationalize services, seek priorities, be very clear on the treatment and referral guidelines. And most of all, provide mental support to those persons who are coping with these NCDs, as well as health professionals who are still recovering from fear of this epidemic.
Thank you, Ruth. Okay, and Dr. Brathwaite. Diane.
Yeah, hi. Essentially, I think there needs to be a much greater focus on preventative care. Preventive care needs to be aggressive, active care, so that we don't have this huge burden of NCDs that we're having, or at least uncontrolled NCDs or NCDs with complications. There needs to be, I think, more input into health literacy, so that we have people who are understanding a lot more basic things, food security. For me personally, I would like to see an expansion, I think, of partnerships where we have a divide and conquer approach to these initiatives, so we're not wasting resources. And then finally, I think efficiency of services. I think there are a lot of places where money possibly can be used more efficiently to deliver the services that you want to deliver more effectively. And finally, a health youth advocacy, because they're a huge resource, and they've been a huge resource to me for a while, so that we pour our efforts actually into empowering them and developing them and utilizing them. Thank you.
Great, thank you. Andrew, Danu.
Hi, Maisha. My camera isn't working for some reason. Yeah, so what we have learned, mostly association, is how to do a lot more with a lot less. We've always been able to do this simply because we've always had to depend on the funding that we had to raise. Now we have additional limitations, and we have learned how to reach more persons using social media, how to reach more persons using mobile applications, but also the limitations that presents. Simply because we know that many of our persons with diabetes are elderly, or many of them have resisted technology for quite some time. And now it's presenting them with more opportunities to learn, and we are pleasantly surprised that many of our members are quite accepting of the technology. So it's something that we now think that we could implement more widespread in the communities, not just with elderly folks, but also younger persons, using mobile applications, using social media, and using these IoT services. We could be able to do more work and again, do with less.
Great, thank you, Andrew. So let's go on to Bernadette Saunders. So your top priority moving forward.
Collaborate more with the Ministry of Health, as they have a CNCD register that identifies clients with CNCD. And if we collaborate with them, we could do more as relates to meeting those persons' needs. We have some programs in place already, and we can match those programs with what they have. So again, like I said, collaborating more with the Ministry of Health and the CNCD department, which should not be a problem.
Great, thank you. Dr. Connell.
Okay, so my 2 points are: one, the establishment of a working group to provide a template for CSOs to use to respond to emergencies. And this working group should include stakeholders from SEDIMA, regional governments, Pan American Health Organization, CARFA, as well as regional security networks, and to create a template that CSOs can follow. And secondly, the use of technology in health and telehealth. There needs to be training in that respect for CSOs and for health in general. This could be in collaboration with academia, but also could be in collaboration with other ICTs. And tying on to that, how can we use artificial intelligence to guide us in fighting the next pandemic?
Great, thank you. And Dr. Tamara Remy.
Okay, sorry, I was muted for a while. So for us as an individual organization, I think we need to continue our advocacy for prevention. That has been like the mainstay, so that when something like this happens, as mentioned before, there are fewer patients than people that we really need to be helping in terms of the consequences of the NCDs. That's going to take a long time. So that's, you know, I don't know, we will not see another crisis for the next 30 years or so, but that's certainly something to work towards. I think for us, we also need to be better at establishing a better patient registry so that we can more quickly reach out to those persons who are in need in whichever ways that we can. So that would involve alliances more closely with the actual services that are delivering services, so like oncology clinics, etc., and how we navigate our way through that. And I would love to advocate for a local NCD alliance so that when we have an immediate response that needs to be ushered through in a time of crisis, that, like was mentioned before, is not duplicated, and we're being very resourceful and specific with the delivery of that service. For example, food delivery. There's so many different companies, different associations doing the exact same thing, while if we did it differently and specifically, we'd probably have a greater effect.
Okay, thank you, Dr. Amy. So on to Dr. Nancy Larco. I'm conscious of time, so just try and be as succinct as possible. Your two top priorities?
Yeah, I totally agree with all what was said before, but I should say that as a social organization, a civil society, we have to take the responsibility and the leadership, as one of us just said. And because we have to show to the Ministry of Health, this is what we are living in Haiti. You know, they are overwhelmed and nobody comes to the NCDs population, the most vulnerable ones. So that's one. And then secondly, I think coalition, not only local, but throughout the Caribbean, as you are doing and very well, but a turn to mental health, which is very important. Sometimes we stay in our corner and don't go to the other one, and also use the technology. It has been a very tremendous possibilities through them. So work with them to be more able to deliver information to our population.
Thank you. And now we have Juanita James.
Hello. Yes, I think the importance of collaboration that has been mentioned, I would support that working together with other partners, that's very important. Also, in our communication, to always to remember that although we are using technologies, for instance, there are persons who would not be accessing social media, so that we have to think of other ways to reach persons who are not as easy to reach during these times. And for us, I think the importance of persons being able to take better care of themselves, you know, even of their mental health and all of that, that's so important when they cannot access regular services, that we have to help to strengthen those areas where they can look after themselves better.
Great, thank you. And then the last word goes to Dr. Mark West. Mark, are you there still? Let's see. Some people have had to, yeah, there we go. You're still muted. Your mic's on mute.
Okay, I'm here. I'm sorry about that. So I was saying I'd like to provide a TSOT response and an individual response. From a TSOT perspective, we need to electronically communicate better with our membership and the doctors that we represent. From an individual perspective, I think we are providing the solution to part of the problem, which is a collaboration, which has been arranged by the HCC, and one has to say thank you so much to that. The challenges from COVID can be divided into direct and indirect. And direct is acute with respiratory disorders, which may eventually become an NCD in itself. And then NCDs themselves, in which we've heard that we need to strengthen our NCD response and how we go about that. From an indirect perspective, where we have heard about the economic impact, the financial and the psychosocial. Finally, we have our building back better, and I think we've already started that with organizational interaction and in governmental cooperation, both at the WHO, PAHO, HCC, and regional. I think the format of or the foundation for a solution for this should be a working group, as Dr. Connell has said, in addition to which we should provide a report for what has been discussed. I mean, we've all seen there's a large number of potential ideas, so that we don't lose them. We should all document them. And finally, might I suggest maybe another HCC roundtable to either build on this, to say what has been done, and to go forward again. Thank you.
Okay, thank you very much. So we've heard strategic planning, that's financial planning or programmatic planning, heavy emphasis on collaboration and the use of technology. And I want to thank the panelists. I'm going to open up the floor now to Sir Trevor Hassell, our president, to close everything off. So Sir Trevor, the mic's over to you. I'm passing the mic, as the WHO would say.
So thanks very much. And what is really very evident that civil society organizations throughout the Caribbean have really truly stepped up to the plate. Civil society organizations over the past many years have contributed significantly to the NCD effort in the Caribbean. But there's no question about it. As I listen to the many interventions, it is quite evident that that you have done so, as they say, big time. In fact, when I reflect on the response to the pandemic as it relates to people with NCDs, I would go so far as to say that throughout the region, this has really truly been led by civil society organizations. And I say quite deliberately, and less so by governments of the region. And so I certainly, on behalf of the Healthy Caribbean Coalition, thank all of you for your significant efforts. Today's roundtable is really part of HCC's contribution then to the response to the pandemic. And so some of you may be aware, we have issued an open letter to CARICOM heads. We've also had a communication plan that we've advanced. And you've also heard about the joint statement that we issued with the OECS. Even as we speak, the HCC is currently planning what we are referring to as a 2-year new NCD agenda to accelerate NCD policy and program implementation. And we're planning to do this over the next 2 years post the coronavirus pandemic. We're going to be sharing a lot more information on this with you, and we'll be looking forward to your fullest participation, since it really will ultimately be your initiative. And so once again, let me thank all of you for taking part in this roundtable. Please let me reassure you that the HCC, as the region's NCD Alliance, will support you as you continue to make your respective contributions to the Caribbean response to NCD in the era of the COVID-19. And so with that, it just remains once again to say thanks very much. Travel safe, be safe. Listen out for our next roundtable. Bye now.